So, hello everybody. I'm uh, I'm uh, I'm saying hello from Slovakia, from the capital city of Slovakia, and I just check if we are ready to set. I think yeah, everything is okay. So. Um, so today's topic is the CBCT, and we are there are some groups, the groups that, for example, the guys or the doctors who have the CBCT in their own practice, or for example, like me, I'm sending my patients to another CBCT to another clinic who has CBCT. And there is this third group that they even don't know what the CBCT is. So I think that for today we will discuss all the possibilities that you have with the CBCT in your practice. So I just want to introduce myself. My name is Roman Blahuta, and I'm a dentist from Slovakia. And as I said, now I'm joining you from our capital city, Bratislava. So feel free to join our beautiful city. And in Bratislava, I with my wife we have a private practice, and we all the stuff in the dentistry that we can do. But I especially are I'm specializing myself in the procedures under the dental operating microscope, and most of it is endo and resto. So the first question is, what is the key of success? And everybody from for everybody has another one, but for me it's all about the magnification. So it's all about the microscope. And if you are doing endo, you must have enough time to do your work proper. Then you must have the proper equipment. Then it is fine if you have something where you can record and present the work to your patient, to other doctors. And today we will speak about the imaging techniques and imaging devices. And also the key of success is the education and the experience that we have during our whole life practice. So look at this. This is my case from last week. I broke this file. It was a traverse file, and as I was doing this horrible stuff, I was thinking what was the problem that I broke this file. And the problem was that I didn't understand the anatomy of the tooth properly. So I hope that in future we will have the possibility that the CBCT will be universal for all cases. That means that, for example, the radiation will be so low that before treatment we can do a CBCT, and we can arrange the case in a proper way, that we know what we are doing in the future. So it is really important to know the anatomy of the root the right way. So everything is about 3D versus 2D. So let's look at our units. So normally everybody in his practice has a 2D RVG. So this unit is for the intraoral X-rays, and it's a 2D unit. So the we see only a shape, so we don't see the third dimension. So when we see the image that we have, it is this one, and we can see, okay, there is the first maxillary molar has a problem, so there is inflammation. but we cannot say how big is the inflammation, or if it's also in the antrum or not. So there are some limitation. When you are doing this kind of images, it is important that you use such of holders, because we want to be we want to have the situation when the cube is perpendicular to the sensor. Otherwise, we will not take a good image. So please use these holders. The same situation is in 2D panoramatic RVGs, and we get also the shape, but when we do a panoramatic picture, we will have this kind of image. We see much more. So, for example, we have the overall view. So I don't use these panoramatic pictures, for example, to discuss if there is caries in the interproximal spaces. My favorite there is the small intraoral image, but we can see the wisdom tooth, we can see the antrum, we can see some if there is a problem in the bone, but here are also some limitation. What's the problem with the 2D image? We know this slim pick, and the problem is that 2D image is a 2D imaging of a 3D object. What does it mean? That first of all, shades can overlap, and because they are different sort of tissues, and we can have some distortion of the image. So how we can do better? So in this case, we can use the Cbct, and as you see, we don't have any shape anymore, but it's an object. So now we have the 3D. So for these are the Cbct units that we see, not the shape but the object. And when we see the case what we had in the small intraoral image, now we see that we have more information. So we see the size of the periapical lesions. We see that there is also a problem in the antrum, so there is a thickening of the mucosis, and we also see on the coronal view there is a the lesion is entering through the cortical bone in the vestibule. So these are all important information that we can use before we start the treatment, and then we can discuss with the patient what are the limitations or what to expect or what will be the complications. So for me, when we have a very difficult case, the Cbct is for me a gold standard in this kind of situations. So the one of you that didn't hear what is Cbct or the DVT, so or DVT in German, because DVT I heard for the first time in Germany, so I didn't know what does it mean. So what is Cbct? So it's cone beam computed tomography. So there is a cone beam and there is a tomography, and the other thing is the DVT is the digital volume tomography. So it's the same word. It's a synonym. So you can hear this or this, but it's the same. So first of all, what is the difference? Because I would say normal CT that we knew from the hospital when we got hurt, and cone beam. As you see that there is a difference of the beam. So in one is in the normal CT, the medical CT. There we have the beam is like a fan, and we see that it's really thin, and also the sensor on the other side is thin too. But as we see on the cone beam, the good thing is that from the tube, the beam is coming in the cone, and it's entering the face, and we see that a much more field is seen. And also on the other side we have a bigger sensor. So we see that, for example, we need low radiation. Why? Because when we see the movement of the CT, the medical CT, we see that as the fan beam is very thin, the unit must do 360 degrees circles around the patients many times, and every circle is the radiation. But as we use the cone beam, there is only one 360 cycle, and we have everything captured that we wanted. So the radiation is much more or less. So let's talk about the sections, because when we talk about CDCT, we must be sure that we know what we can see there. So as in this medical normal CT, we have these slices: is the axial or the transversal slice, then is the sagittal slice, and then we have the coronal slice. And it's very important to know these slices, because when we go to the, for example, to the practical side, we will talk about these slices, so please remember. So let's talk about the shining or the radiation, because it's very important, because every one of you have some patient with when we are talking or saying to them, okay, we are doing X-ray today, and they are like, oh my god, really I will not radiate or something like that. So you must speak about with the patient and explain to him why, for example, there is a radiation, or why we do that. So it's very important. So the first thing that I tell this patient is that, do you know about the radiation from the nature? So the patient must know that every day on Earth he gets some radiation. Okay, this is very important. So if somebody is saying this is the only radiation that we are getting is from the medical unit, he is not right. So let's talk about this a little bit. So if we are talking about the unit of absorbed radiation dose, so we are talking about the sievert. So, but the sievert is quite big. I would say it's a quite big measurement. So we are using a lower measurements like microsieverts or microsieverts. And in this we can speak about the radiation doses. So let's speak about the radiation from the nature. So every year we get exposed from the nature in a manner of 2,500 microsieverts. So when we see and it's the radiation is from the cosmos, so it's a cosmic radiation. So then it's the radiation from the radioactive elements. And then it's a big part of this radiation, it's radon. So every day on Earth we get a dose of 7 microsieverts. So this is, for example, when we make an intraoral picture, then we can say to the patients, look, you get every day you get some radiation. And for example, if you fly from New York to Tokyo and you make a round trip, then you get the radiation dose of 200 microsieverts. And as we look to the medical sources of the radiation. So, for example, when we have intra or picture, then we have the radiation between 1 till 8 microsieverts. When we have a panoramic picture, it's between 4 and 30, and the CBCT is between 50 and 100 microsieverts. And we can use also low doses, and then we can go a little bit lower, for example 11. And when we have a CT, the normal one, the CT from the hospital, when we have a CT of the head, then we get about 2000 microsieverts. And when we are taking a CT of a thorax, then we get 6900 microsieverts. So you see, for example, that the CBCT and the CT, there are very big differences with the radiation is. So about the ionizing radiation. So when we are doing some X-rays, it is important that we always have that we can justify the radiation. So there must be a reason to do the X-ray. The other thing is that we must optimize the radiation. What does it mean? That, for example, if we can choose as low radiation as it gets, that we get a good image, then we should make the image with the lower radiation. The other thing is that we do the application of diagnostic reference levels. This is a thing that is calibrated on the units. Then we should monitor and rate the size of patient radiation. What does it mean? So, for example, when I do an intraoral picture and I do it on the first molar, so it's important that I write it on a paper, and when then I can take it in the future and see, for example, what size of radiation the patient got. And also it is very, very important that, for example, when the patient is for example, oncologic patient who is receiving ionizing radiation, for example, to battle against cancer, that we must know this information and add it to our, for example, radiation. And it is also important by the ionizing radiation to inform the patient of possible risks. So, as I said in the beginning, it is really, really important to inform the patient that when we apply the radiation to the patient, then that is safe, and we are doing it because it's very, very important. So this is the paper that was released by the European Society of Endodontology, and it was about it was a position statement and the use of cone beam computer tomography in endodontics, and it's free to share on internet. So I will not going through the paper. I just want to pick some indication. What are the indications for CBCT? So first of all, it's when do you have, for example, periapical pathology and the symptoms do not fit to this pathology. For example, there is a small lesion, but the patient has great pain, or there's, for example, pus discharge or other symptoms, and you are not so sure what to think about it. So here CBCT is a good thing. Also, when we have trauma or we have a suspicion that a fracture is in the tooth, so this is also a CBCT indication. Another is a difficult anatomy. What does it mean? For example, dens invaginatus, but it's not so often, but we have obliteration and other, for example, curved canals and stuff like that, because we can prepare for such a difficult anatomy before the treatment. Other thing is re-endo. As I said, the re-endo for me is a golden standard. The CBCT is by re-endo or the partial root filling. We will speak it in the future. And also when we have a big periapical lesions with, for example, pus discharge, these are also indication for CBCT. Also PA, periapical surgery, then endo versus implant, and we are not, for example, when we have these big PA lesions, and we want to, after 1, 2, 3 years, we want to be sure if everything is okay. So yeah, we can do a small intraoral image, also a panoramic, but in this kind of situation, we always do also follow-up with the CBCT. So the question is, for example, for those of us who have no CBCT or thinking about buying one, so how to choose a CBCT unit? So the first question is, why are so many CBCT units on the market? And the answer is that it's because there is a development of the sensors technology. So we can have a combo sensor. So in the unit, the panoramic and the 3D image is made by the same sensor. And then we can have a dedicated sensor. So for example, that is the situation when each sensor is taking the panoramic and the other one is taking the 3D. And then we have the dedicated CBCT units, and those are when they only making when they are using only the 3D sensor. So for this, for example, this kind of units cannot do a panoramic image very well. When we talk about CBCT, we must also talk about the field of view. So in other words, what can we see as we take a CBCT? So the field of view, it is also the height and the width. So the first, for example, when we have a small field of view, 8 by 8, so it's the height and by the width. And medium is for example, they are 9 by 14. So the first number is the height, and the second number is in the width. And then we have a big field of views where we can see, for example, the maxilla, the mandibula, the antrum, and other things. And that is a large field of view, for example, 17 by 23. So the question maybe for you is, what is the proper side of field of view? Because we are buying the CBCT according to the field of view. So some of them have small field of view, for example, 5 by 8 or 8 by 8. Some have a bigger one. So the question that I will try to answer today is, what is the proper size of field of view for you? Okay, so for each indication, the optimal field of view is different. What does it mean? But first of all, let me say that that KaVo groups together all these companies. So KaVo is grouping the Gendex, the iCAD, the Soradex, and the Instrumentarium. So if you have KaVo, please keep in mind that inside the unit there is some of these companies inside. So I think it's a quite smart idea to get from every company a little bit and to do it in the finish a good product. So look at the KaVo imaging portfolio. So we are starting with the OP2D, what is the basic panoramic unit. So in this kind of unit, you can do only panoramic images. So when you want to enter the 3D world, so you go with the OP3D, is a basic model, and as you see that as you enter the 3D, you can do ortho, you can do endo, and you can also do implant. So when we are talking about endo today, so this OP3D is good enough for the endo, but if we want to be more versatile, for example, then we can go also for the OP3D Pro. So, for example, he has a touch screen, or you can have much more function in this kind of unit. And the OP3D Vision is upgradable 3D system, and it's for the most difficult tasks. What does it mean? That you can use it in maxillofacial surgery and also in oral. So the question is how to optimize the radiation in CBCT. So first of all, you must be very precise, and it is nice when your unit has something like the scout image. What does it mean? A scout image helps to control the size and the place of the image, or the place we are imaging. And the scout image has lower dose.
I think that you are not sharing the screen. Sorry for interruption, because I can see your camera, but I don't see the presentation at all.
Aha,
So,
sorry. Shit. Yeah, you see it now?
yes, now it's okay.
Yeah. Okay, so okay, sorry for that. So I go here. Okay, so yeah. So as I said that this KaVo imaging portfolio has this kind of units. So it's the OP2D, OP3D, OP3D Pro, and OP3D Vision. So as I said that the OP3D is the basic model for entering the 3D world, and it's for ortho, endo in implantology. And if you want to be more versatile, so you can go with the OP3D Pro, and the OP3D Vision is for the really hard cases. So one more time, how you can be precise in the CBCT. So it is nice when your unit has something like the scout image. So a scout image is something like that you are taking a picture before you are taking the CBCT. So it helps to control the size and the place of the imaging, and it's a lower dose compared to the intraoral image. And it is useful when you are doing a small field of view, because as you are doing a small field of view, you are not sure maybe where you are. So this is very helpful, because it would be very bad if you had to take another CBCT. So let's talk about the resolution. When we talk about CBCT, then we are talking about the voxels. It's compared to the pixel is a 3D object. So when we have a 2D object, we are talking about the pixel, and when we are talking about the CBCT, we are talking about the voxel. So a standard resolution in CBCT is something about between 200 and 300 micrometers. Then we have a low dose, what is about 300 to 600 micrometers, and then we have a high resolution, what is between 125 and 200 micrometers. So it's like the bigger the resolution, or the bigger the dose. So if we have a nice picture, then you must know that the dose was really high there. So if you look, for example, CBCT, what we can do, where we can do a maxilla 16 by 6 or the dentition 8 by 8, then we have many choices. We can do a high resolution scan where we get about 85 microsieverts, and also we can do a quick scan with ultra low dose, and then we have only a dose of 5 microsieverts. The same situation is, for example, if we go to a bigger field of view, then we can have a quick scan where the dose is 9 microsieverts, and if we go really sharp, so with the high resolution, then we get a much more big number. So this is what I said, that we must be sure, or we must think about if we need a really sharp image, or if we can do a little bit not so sharp, but the dose will be much more lower. So if we look, for example, a quick scan and a standard scan, then we can say that there is not so much significant loss of information when we do the standard scan against a quick scan. And this is the dilemma. Do we need always a beautiful image, you know? So what about CBCT and Endo? So for me, CBCT is crucial for the endo treatment, especially in hard cases. So there we must use high resolution. So for example, it is 125 micrometers when we do the ultra high definition. And but we can go even less, so we can go very sharp with a small field of view, 5 by 5, and then we have a resolution of 85 micrometers. So in the KaVo units, if you choose to go for a high resolution, the unit automatically forces you to go to a small field of view, that the patient doesn't get so high radiation. So the same is here. As the resolution gets up, also the dose that the patient gets up. And we will talk just in a few seconds about the software. But in Vivo 6, what is the preferred software for the Endo CBCT units? Then you can also do the endo visualization, the endoscopy, and also the dental pulp imaging. So why to choose a small field of view in Endo? So, for example, here you have the picture on the image on the right, where you have a big field of view. You see that you see the whole arc, and when I cut and when I make the picture or the image bigger, you see that we are losing the resolution. So we don't see the image so sharp as we would. So it's bigger, yes, but the resolution has gone. So here a better way to go is to choose a smaller field of view, for example 5 by 5, and you see that now I can make it bigger, but not outside the program, but in the program. And I see that the images are bigger, but we are not losing the resolution. So what about the software? We have two choices. So in the KaVo units, you can have the in Vivo 6 software or in on-demand. On-demand is more suitable for implants. So we will talk today about the in Vivo 6. So the in vivo 6 is made by the company Anatomage from United States, and they are doing a lot of stuff for imaging. So, for example, these tables where you can learn something from the anatomy. And what is so nice about the in vivo software? So there is a direct connection to KaVo, Gendex, and iCat. The good thing is that is an open standard DICOM format without integration. I will speak about it in a few seconds. You can create the radiologic records, and there is also a possibility to share it with your colleagues in the cloud. Has endo function, as I said, and you can do there a 3D reconstruction of external and internal anatomy. And the question is, are you also attacked by different CBCT programs? What does it mean? For example, Monday you get something from iCat, Tuesday you get something from Romexis, from PlanMeca, or Wednesday you get a CBCT, what is in other software. So what is good about the in vivo 6? So the in vivo 6 works as a browser. So you will browse, and you will browse to the file on the CD. So you put the CD on in the computer, and you find it in your files. So, for example, this is a CD that is made in Romexis. So it's PlanMeca, and I wanted to open it in the in vivo 6. So I choose data, and when I click the data, there are these icons, and normally all the images are in the images. So I click the images, and I will find this kind of files. And as you see that there is a file DCM, and it's really big. So this is the file where all the images of the CBCT are. So I click, and this the in vivo 6 is opening these images, and this is my main view of the in vivo 6. You see there the sections, the coronal, the transversal, the axial, the sagittal, and you have there many options. For example, you can arrange the picture, the images. You can, for example, I use when I want to get the images from this program to my computer. So I want to extract this image, so there is no problem. Then you can send it to somebody. So enough of the theory, and now we are going to show some real life. That means we are going to the clinical cases. So, for example, the CBCT you can use to do as a confirmation for peri-epical findings. So here was the questions: is there or is there not a lesion on the apex? So if there would, maybe we would try to do re-endo, or we would extract the tooth. But there's the problem with the post. There's the problem with not so much space. So we can do CBCT. The patient had this tooth for a long time. He has no problem with it. So the question is there or is there not a finding, and do we re-endo or no re-endo? That is the questions. I don't know what about you, but for me, bad looking root filling is not a diagnosis. The diagnosis, for example, is periodontitis apicalis chronica. And another thing is when a not pretty looking root fill is seen without a PA lesion and patient has no complaints, so we don't do re-endo. Myself definitely no. And the only thing is to think about our situation where a prosthetic work will be placed. So, for example, a crown will be go there, and the patient is paying a lot of money. And we must think about the situation that, for example, in the future, there can be a problem, and there is also the crown and stuff like that. So we must think about it. But normally, when there is no PA lesion, we are not doing re-endo. So we do the scans for first we see the coronal view. There is no finding. Then we see the axial. Still nothing. So that was the case where we leave the tools like this, and we are doing not the re-endo. Another good thing about the CBCT that we can use it when we are not very clear about the anatomy. So look at this case, and uh, so I go back. So this was the situation, and I done their root fill, but the problem was that it was referral. So I did this case, and the doctor before me tried to do endo through the crown. And as you see that he perforated the crown on the other side, so he was totally wrong the way the root canal is. So I did it in this case without the CBCT, but we can be not sure every time when where we are. And look at this case. This is my case, and I did it like 5 years ago or 7 years ago. And at this time I didn't use the CBCT. I couldn't find the root canal, but I put a post inside and made the crown. What from this point of view was not so smart, but at this time I didn't have the CBCT. So I tried to do the re-endo because now after 7 years or 8 years I'm a big doctor. So I tried, and look where I got. So the second time I was wrong. So I couldn't find the root canal. But nowadays, I have my CBCT. So after the attempt, I made this CBCT, and I finishes my preparation just right, because otherwise I would do a perforation on the palatal side. So I done this CBCT, and now I know where to dig or where to find the canal, because when we are looking at the axial slices, so here is my I almost perforate the root at this place because my preparation was wrong. So where I had to look at this place, so I must go much more vestibular. So this is a very important information that you get, because now you know where to do the preparation. So this is before and after, and you wouldn't say about the root that or about this case there was so much that was so hard for me to find it. And this is what I got. So they are like two canals. One is right, one is wrong. So I did my pre-endo from I adhesively sealed the wrong one, and then I put a big pose inside. done the preparation and made the new crown. So, and it works. So here is another referral case. This patient came to me, and there was the thing to do the endo on the second maxillary molar. There was a pus discharge, and I thought, okay, so they didn't find all the canals, maybe they didn't find the MB2 or the MB1. So I will fix it, and everything will be all right. So here we see the massive pus discharge, and as I open in the first session the second maxillary molar, we see that I found the palatal, I found the distal buccal, and I also find the mesial buccal. And I found a perforation that went under the crown, and I thought, okay, this is the reason why the pus discharge and the problem on the tooth is. So I sealed it, and the patient came to the second session, and the pus discharge was still there. So I knew there must be another reason. So I made a root fill, and I did. I sent the patient to the CBCT, and the patient came. So I checked my maxillary second molar that I done the last time. So this is the palatal, and this is the distal buccal, and here is the mesial buccal. So we see that the MB1 and MB2 are joining. And now let's look at the first maxillary molar. So this is the mesial buccal. We don't see anything, but as we slide it through the distal buccal and the palatal, we see that here are the lesions. So the reason was not the second maxillary molar, the reason was the first one. So the doctor choose the wrong tooth. So this was the reason for the pus discharge. So here was the problem. And as we see on the axial slice here, we see the loss of the cortical bone, and we see that even as the pus discharge was from the area of the second maxillary molar, the reason was the first one. So as I open the tooth through the crown, we see the pus coming out of the tooth. And on this first session, we are cleaning all the pulp chamber, and we are dressing the tooth with calcium hydroxide, and we close the tooth. And when the patient is coming for the second visit, we see that the pus discharge is closed, and we see also when we open the chamber that everything is clear. So we are filling MB1, MB2. We are filling the palatal, and we are filling the distal buccal. And then we are closing it. For example, here I close it with dual cure cement. This is a white one. So in the future, as maybe there is the chance that we must go inside the tooth, so it's a little bit easier to get rid of this cement, because it is in a white color. Then we can protect the ceramics. We can sandblast it, and then we can adhesively make a filling. So this is the feeling, and the patient is happy and no problems. So this is before, and this is after. So what about the big PA lesions? As I said, when I have this kind of situation and I see, okay, it must be re-endo, we see a big lesion, and we see also that maybe the distal buccal, there's resorption. So I always tend to send the patient to a CBCT, and as you as you saw in the previous slide, this is what we see. So we see the biggest problem is that there is a thickening of the mucosa in the antrum. So we must be very careful. For example, when we are doing the root filling there, we are using downpack and backfill. So we must be very patient. We must be very soft with the force that we apply to the filling and to the sealer. For example, we should use here. I used here a bioceramic sealer that I don't push the sealer behind the tooth and maybe into antrum. And we know that, for example, this will seal a long time. So if we take a X-ray, for example, in half a year, we will not see totally healing. We must wait. And yes, in 1 year, I will take here a small field of view CBCT just to be sure that it's good healed, and also what is the situation in the antrum. So here is the coronal view, and we see that the cortical bone is destroyed. So look at this big PA lesion. This is the PA lesion. In this, when you have a big PA lesion, you must be sure that that it's a lesion of endodontic origin. So that really tooth is responsible for such inflammation, and that is nothing else. So different diagnosis is very important, and also a CBCT. So this is the patient that came to me in 2017, and you see that there's a big resorption of the bone over four teeth, and we see all the slices, and you can see also this 3D reconstruction and the resorption of the bone from the palatal side. And in this place where the resorption is, there was a pus discharge. So I tried to dress it with calcium hydroxide, but after four months of dressing with calcium hydroxide, the pus discharge didn't disappear. So I spoke with my surgeon, and he told me, okay, make such a window in the place where the resorption of the bone is. So you take your electric device, make such a window, and I excoculated all the space, and there were like some pus flakes still in the hole. So I excoculated it, and the patient was rinsing this place with antimicrobiotic solution with chlorhexidine. So he did it for 2-3 weeks, and the window closed every day a little bit. So, and after 1 month, it was totally closed, and there was no pus discharge, and the canal was totally was not wet, and I could do my root filling there. And this is the situation after 6 months. and you can just okay, say okay, the healing has occurred. But if you want to be really sure, you should make after 1 year or 2 years CBCT. So then we made a panoramic X-ray, and the healing is nice. We see that maybe there is a lesion of the second maxillary incisor, maybe. But look at the CBCT last year. So we see the axial view. There's a really nice healing. We see from the sagittal view, and we see also the coronal view. So we see that the healing is really nice. And as we compare the situations 2017 and 2 years after, you see that already the bone on the palatal side is growing. So this is a really good result. And we can check also the 3D reconstruction, and we see that these lesions of the bone are, I would say, 50 or more percent less. So let's look at the third maxillary molar on the right side, the tooth number 16. So there was this patient. I renewed almost all the endos that he have on the left side, and now it was time for the tooth 16. He had there a gap because he lost the second maxillary premolar. And what happened was that we were thinking about to make there some reconstruction, because we see that under the crown on the 16 is decay, and also a very big lesion. And the same is a panoramic image. It's only 2D. We cannot say if, for example, the antrum is inflamed or no. But what happened is that the filling on the first maxillary premolar broke, and it broke all the tooth. So this tooth had to be extracted. And before that, we done the CBCTY. First of all, because of the PA lesion of the 16, and the other thing is, as I said, is always for example, endo versus the implant. And I send it. I send it to my implantologist, and he can prepare for the implantology side. What does it mean? That, for example, he can predict if there must be done some editing procedures like additional bone or sinus lift and stuff like that. That also the patient is informed before what he can expect. So here we see all the problems with the endo. We see the big periapical lesions. We also see that there is the root canals are not properly filled. On the right image, the lower one, we see that the MB2 is not treated. And we also see that the PA lesion made push the bone inside the antrum a little bit. So these are the problems that we have. So this is the situation. I didn't get rid of the crown because otherwise I couldn't make my isolation with the rubber dam there. So I found the metal post. You see that under the crown there is a way to get out. So you must seal it temporarily, that no moisture is coming into the crown. So you can put there some flow, a colored one, for example, a blue one. And now you are trying to find all canals. You will find the MB1, MB2, the distal buccal. You see that I have still the post in the palatal because the case was so difficult that I had to do it not in one, but in two or three sessions. I don't remember anymore, but more than two. So I decided I will do the one side with the MB1, MB2, MB and the distal buccal, and then I will do the palatal. And the palatal root was very interesting because, as you see that in the deep region there is a dividing of the palatal. So there were like two palatal canals, and I cannot imagine to fill this canal only with downpack and backfill method. With this kind of technique. So here you can see this is after filling all the two palatal canals, and now we can put a post inside. Here we done the backfill, and adhesive procedures. I used here the OptiBond FL, and you can cement your post. So this is the X-ray after the procedure, and you see that it looks like a snake tongue. So here is the reason why it was so difficult, and we see the dividing of the palatal root canal. We can check it also. We can check it also on a Cbct afterwards. So this was done, I think, about 6 months later, where the tooth that was extracted had healed, and the implantologist wanted to see if the situation on the first maxillary molar is going better. So as you see, we have the MB1, MB2 sealed, the distal buccal and the palatal, and we see that also the bone that went to the antrum is now normal. So we don't see that the bone we see that the bone is healing very good. So now there is no problem to do implant. So here is the coronal view, where we see that the bone is healing very well. And also the sagittal view, we see that there is a small inflammation, but when we compare the two, that we see that it will be better every day. So it's very important that you see the progress, because sometimes we cannot wait like 1, 2, 3, 4 years, but we must see that there is a progression, and that the lesions are going they were big, and now they are less. So every one of you maybe has a skeleton in the cupboard. What does it mean? That in the past you did something and you were not 100% sure, and now after some years it will come back, and you have the funny feeling, okay, that something went wrong in the past. So let's look at this case. So we see this maxillary first molar, and it came to me in 2013, and we see that only the palatal and then the distal buccal is filled, and the mesial buccal root is empty. So I removed the crown, and I did my filling on the mesial buccal, and the time went by. And I made my X-rays every 2 years, and I done this X-ray in 2017, and I was okay, looks quite good. But last year, I think the patient came and he has a past discharge on this tooth. So, and I thought, okay. And I made my intraoral X-ray, and yeah, this was last year. And you see that always when you have past discharge, it is nice to take a GP point and put it in the past discharge, and you see where from where the pus is going. So always when you have a past discharge, put a GP cone and made X-ray with it. And oops, I forgot to tell you that I didn't find the MB1 in 2013. So I was so big that I found the MB2, but I didn't find the MB1. As I said, 7 years ago, I didn't use CBCT. Why? Because I must say because it was a failure for myself. But I must say that at this time in Slovakia, it was not so often to use CBCT. So let's look on the slices. So we see on the coronal slide that sorry, this is the sagittal, that there is the root canal. So as I saw it, I said, okay, yeah, there is no such thing as the first maxillary molar will have only the MB2 and not the MB1. And as we see on the axial slide, that here is the place where the MB1 is, and I can measure it in for example in Vivo 6, and I can be really precise where I should look for the MB1. So I found my MB2. I drill through the crown, and now is the time to find the MB1. And I didn't need much time, because I knew exactly where to find it because of the CBCT. And I prepared. I made a preparation, and here is the preparation, and I also did the retreatment in the MB2, because there is a slight chance there are some communication between the MB1 and MB2. So if we are doing such a stuff, I always recommend also to remove the MB2 too, because there can be some communication. Now you just put your calcium hydroxide dressing inside, and next time when the patient is coming, the past discharge has gone, so you find the reason, and you can be 100% sure that if you will done it, you will do it proper, the patient will have no problems in the future. So next time when the patient is coming on the second session, you just check, no pus is coming out, the dressing is nice, and you just feel the MB1, you feel the MB2, and this is before and this is after. So now it's proper done, and this is one of my skeletons from the past. Other thing is that when you have a picture and image, and it doesn't matter if it's X-ray or a 2D or a 3D or a panoramic one, always don't look just, for example, if you do endo, just for this thing, but always look in big picture. So check everything. Okay, I just want to present you this case. So this was the situation. I tried to do re-endo on the first maxillary incisor, but as I did it, I pushed over the apex some MTA, and the patient didn't came a few times. He had the appointment, and then she broke this tooth, and an implant had to go there. So okay, that's no problem. But we did CBCT before the implant with large field of view or medium field of view. And as you see that as we went through the CBCT, we discover that this patient has a big problem, and maybe you can see it. And the problem is that the sinus tracts are totally inflamed, so totally full. So no air is coming inside. And as you see that there's some sealer inside the sinotrax, so the sealer was pushed there in the past, and this is the axial view. So and the patient told me that he was complaining many years uh, about some feelings that he had. He went to the doctor, but the doctor said everything is okay. So we had to do this to discover such a thing. So look at these sagittal views. We see that in the past there were maybe some endo was done, and then the second premolars were extracted. Maybe there was perforation in the antrum. We don't know, but this was the result. So first we didn't do the implant, but first there was an anthrotomy made, and this problem was solved. So, and again, this is the indication for CBCT, where you do a CBCT afterwards, where you check if the anthrotomy was successfully. We see that there is a little bit of thickening of the mucosa in the antrum, but now the patient has no problems. So at the end, some take-home messages to the isolation. So first of all, CBCT is a part of modern dentistry. So don't be shy to use CBCT as soon as possible. Has many indication groups and many situations, as we said before. For example, when we do endo, we need high resolution when we are looking for fractures and other things. So sometimes high resolution is necessary, but use it with small field of view. We don't need always a beautiful image. So decide if, for example, if we have a big PA lesion, we must do it in a high resolution, for example. Lower resolution, maybe it's okay. Use a user-friendly software, because otherwise you will have, for example, a good CBCT, but you cannot work with the software. So choose that is really user-friendly. Select a unit that is individual for you, for example, with field of view that you need, and always look also for the service, and that somebody is guiding you through the unit. And for me, in the many situations, for example, in Endo, it's already a golden standard, and I hope in the future it will be the golden standard as a small intraoral 2D image. So at the end, thank you for your attention. Sorry for the start of the webinar that you couldn't see all the slides. If you want to write me, please write me, and you can also check my websites. And if you have some specific questions, what the KaVo units depends, like what would be the right unit for you, please contact Lucy Žehorová in the Czech Republic, or Mateusz, who is really a big expert what the CBCT goes. So don't be shy to contact them. So thank you very much. And Mateusz, do we have some questions?
Yet. If you have any questions, I'm talking to the participants now. Just ask them now, or you can write us an emails, as Dr. Roman said. So it's okay.
Okay, so if you have no questions, so one more time, thank you very much to all participants, and thank you very much to all KaVo Care guys, especially today, Mateusz. Thank you very much for being the host, and see you soon.
Bye.
Bye.